Hello, everyone. On behalf of the International Bipolar Foundation, I'd like to say thank you for joining us today. We have with us Dr. Martin Beaulieu, and his research is aimed at understanding how signaling mechanisms responding to dopamine and serotonin intersect with the functions of molecules involved in mental illnesses. In the course of this work, he identified a new molecular target responsible for some of the behavioral effects of lithium in animal models. Dr. Beaulieu and his group are presently investigating the suitability of this new target for the development of safer and more efficient pharmaceutical treatments for bipolar disorder. Dr. Beaulieu will share with us what is known of the pharmacological actions of mood stabilizers and explore how this can provide new avenues for the development of better treatments. We're very pleased to have you with us today, Dr. Beaulieu. Welcome.
Hi. It's the first time I do presentation like that. I hope it's all going to be fine. So today we'll talk about what we know of the pharmacological treatments of bipolar disorder, and for that I'm just going to start with a little bit of context. Okay. So bipolar disorder is one of several known mental illnesses which are affecting about 25 to 20 to 30% of the American population. And these disorders are ranging from mood disorders, including bipolar, to schizophrenia, anxiety. We could even count alcoholism and substance abuses in there. It's a huge social health burden. It's kind of but I think you all know that, neglected burden as well. And if we look at bipolar disorder, which is part of this group of disorders here, we're talking about a prevalence of about 2% of population, so about twice the amount of schizophrenia, and much more than things that are more fashionable, like Alzheimer's disease, for example. So how do we treat mental illnesses? But there are several approaches, psychological treatments, etc. Pharmacologically, most of the psychoactive treatments we have today come from approaches that were discovered by pure chance in the 1950s, late 40s, early 50s. So all the therapeutic principles of antidepressants, antipsychotics, all come from this era and were perfected after. And how this works, but most of the drugs are acting on a handful of neurotransmitters, which are called monoamines, because they are derived from aminergic amino acid. And the three main neurotransmitters that are modulated by the drugs are serotonin, dopamine, and norepinephrine. Serotonin is the neurotransmitter system that is the main target for antidepressant drug. Dopamine is the neurotransmitter system that is the main target for antipsychotics. And how does this work? Well, essentially here you have a neuron, and neurons are forming a network of contacts in the brain. The neuron is going to receive information from different dendrites, so generally from other neurons. This will generate a data treatment at the level of the dendrites and cell body, generation of an action potential, which is a depolarization of the membrane that will pass the signal along the axon and to the end of the axon, where a neurotransmitter will be released and the message sent to other neurons. And if we zoom in on this is a structure we call the synapse. And the synapse is the termination of the axon of the neuron that sent the signal, and a specific space on the dendrite of the axon that received the signal. And the neurotransmitter is a chemical messenger that will pass from this neuron to that we call the presynaptic neuron to the postsynaptic neuron. And the reason I tell you that is that most of the drugs that are prescribed, antidepressant and antipsychotics, are acting at the site of the synapse. And what they do at the synapse is that you have here a typical synapse. The neurotransmitter is here. It's released. It diffuses in the synaptic cleft, and it goes to act on receptors on the other neurons. The neurotransmitters cannot stay there forever. It's recaptured by molecules that we call transporters. And what this is an example with serotonin, but an antipsychotic would act here on the receptor by blocking it. And in antidepressant, most antidepressants act by blocking here the transporter of the serotonin, therefore increasing the amount of serotonin in the synapse. So your SSRIs would act at the transporter. MAO inhibitors do something similar. They prevent the degradation of serotonin by an enzyme named monoamine oxidase. And antipsychotics generally block either serotonin receptors or dopamine receptors or both. All these drugs are prescribed to people with bipolar disorder. People could receive SSRI for depressive episode. People could receive antipsychotics. They would have an effect on mania. I know several people receive different adjust polypharmacy of different of these drugs. And what is, just to show you what is a receptor, the analogy, classical analogy for a receptor is that a receptor is a molecule that recognizes the messenger outside the cell and send a message inside. And the analogy to that is a lock and a key. So the messenger is the key, the receptor is the lock, the receptor receives the messenger and send the message inside. And all the receptors affected in psychiatric illnesses are what are called affected by drugs used to treat psychiatric illnesses are what are called GPCR, or G protein coupled receptors. They all have the same shape. They have 7 domains passing through the membrane of the cell. The neurotransmitter will bind somewhere outside. The message will be sent inside. And these G protein coupled receptors represent about 25% or more of the targets developed by the pharmaceutical industry. So it's fairly general, and we understand that fairly well. And the G protein coupled receptor then passes message inside, and they use different other molecules for that. So they will activate. You can think of a domino chain, domino falling, domino number 1, make domino number 2 fall, domino number 3, etc. So your receptor here will activate different what is called signaling molecules inside the neuron, and this will change the property of the neuron and allow for information to be treated. I know it's fairly abstract. Problem is that's what we're working on. And if you want to add another image for that, it's a little bit like a Russian doll. So the brain is one thing, the neural network is something else. And then inside the cell, you have other networks of these molecules that are activated by receptors that are going to do something. So it's network within network within network. And what we're trying to do on our side is to understand how these networks work. Because we have genetic studies and biomedical studies that were done on bipolar disorder and other mental illnesses, and they show that dopamine and serotonin are not that important for causing the disease. What appears to be important is mutations in molecules that are involved in intracellular processing of information. So what we're trying to do now is to understand how the treatments that are given to people and the risk factor for the disease are interacting together to explain why the treatments work for some people on some symptoms. And from that, we hope to be able to get better understanding of the mechanism of the treatments and then get rational approaches to develop better treatments. So what about bipolar disorder, or what about lithium? Because lithium is a prototype of a whole class of drugs that are prescribed that are called mood stabilizers. So you will have valproate, lithium, lamotrigine, lamictal that are part of this class of drugs. And this class of drugs is a bit peculiar because in contrast to antidepressant and antipsychotics, we know these drugs work, but nobody on the planet could tell you for sure how these drugs work for treating bipolar disorder. And that's a bit historical. Lithium was introduced to the treatment of bipolar disorder in 1949 in a scientific article published by an unknown Australian doctor named John Cade. And what Cade did is he was convinced that mania were caused by a toxin in the blood of the patient. He tried to use urine from these patients to make guinea pigs manic. And during this experiment, he discovered that lithium was good to solubilize something in urine. And then he realized that lithium by itself was actually quite calming for his guinea pigs. So that was another era. He was a doctor. He jumped directly to giving lithium to patients and found that it was working. From there to the 1970s, there were studies to really show that lithium is working. And lithium was introduced in the United States for the treatment of bipolar disorder in the 70s. So we know it works, but since we don't know how it works. And to go there, what most people think now is that lithium is somehow working on these intracellular signaling molecules and not on the receptors themselves. And one first block of this hypothesis was discovered in the 1970s that lithium and magnesium are having about the same size but not the same charge. And the theory that was put forward at the time is that lithium was competing with magnesium, and magnesium is an important element for the action of several enzymes in the cells. And among these enzymes in the 1980s, an hypothesis was emitted that lithium was actually affecting a signaling molecule named inositol. And if you bear with me here, when the G protein coupled receptor is activated, some of these G protein coupled receptor activate an enzyme that is transforming inositol to signaling molecules that then go and activate different cascades of response in the cells. And the discovery was made that lithium inhibits inositol enzyme in charge to recycle this signaling inositol to non-signaling inositol. And the hypothesis was emitted that the lithium was lowering this stock of inositol, therefore presenting new signaling to occur, therefore calming down the response of the cell. It's a nice theory. It's around since the late 1980s. However, when tested in animal, it doesn't replicate the effect of lithium. Another theory that was first stated in the 1990s is that lithium is also a direct inhibitor of a protein, an enzyme in the cells that is called glycogen synthase kinase 3. And that lithium is a direct inhibitor of glycogen synthase kinase 3. It's also a nice theory. Turns out that if we inhibit glycogen synthase kinase 3 in animals, we get the same effect in lithium. Moreover, if people that have studied bipolar disorder have identified mutations in glycogen synthase kinase 3 in families or in patients with histories of bipolar disorder. So it sounds like a good candidate supported both by genetic risk factor and biochemistry of what lithium might do. However, the problem is that lithium inhibits glycogen synthase kinase 3 at concentration that are higher than what is given to patients. And actually in concentration that would be toxic if reached in patients. So again, it's holding more or less the road, but we seem to be a little more on the right track. Now, glycogen synthase kinase 3 is itself regulated by another enzyme that is called AKT, and AKT is activated and goes and inactivates glycogen synthase kinase 3. And what we found about 10 years ago is that and this is, you see the style when I say networks. We showed about 10 years ago that the dopamine receptor 2, which is the target for antipsychotics, for several antipsychotics, however, is actually inactivating AKT and therefore leads to an activation of glycogen synthase kinase 3. Moreover, it was discovered about at the same time that lithium not only inhibits glycogen synthase kinase 3, it also acts as an activator of AKT. And essentially what happens is that the dopamine is activating the receptor. The receptor is recruiting a molecule that is called arrestin, and arrestin is itself recruiting AKT and another kinase, another enzyme that is in charge, that is called PP2A, another known risk factor for mental illnesses, that is inactivating AKT. So you have the dopamine receptor is activated, recruit the arrestin is recruiting the AKT, PP2A is deactivating AKT, and then GSK3 is free to be active and roam around and do whatever it does in a cell. And what we showed a little bit later is that if we give lithium to mice, this mechanism of inactivation of AKT is disrupted by lithium. And this is happening at concentrations that are therapeutically valid. So what we're trying to do, and several people are trying to do now, is to see if this could be used as a drug. So first thing we did is we removed this beta-arrestin from mice. And you will see here that if we give lithium to mice, the phosphorylation, the activation of AKT is up. And the phosphorylation of GSK3 is up also, but phosphorylation turns GSK3 off, not on. So AKT activity is higher, GSK3 activity is lower, and when we have mice that do not have the arrestin, well, lithium does nothing on these two molecules. Yeah, nice biochemical trick. What about behavior? So if we take two tests that are used to test antidepressant activity, we see that lithium is having here an effect. It reduces the time a mouse stays immobile in this test. Antidepressants are doing the same thing to the mouse. Does nothing in the arrestin, mice without the beta-arrestin. In this test, this is more emotionality, anxiety aspect. The mouse is in a black box, and the lithium is reducing the hesitation of the mouse to go and explore a place that is brightly lit. We see that in the mice that do not have the beta-arrestin, we do not have this effect. Since then, we have shown that these two effects are modulated the same way by the activity of GSK3. So how can we try to do something new with that? Well, we can target several things. There's a group in North Carolina right now that I know of where they are trying to develop a new type of antipsychotic that would only act on this part of the activity of the D2 receptor and leave this part intact. So that would be some sort of a partial antipsychotic that may be useful for the treatment of schizophrenia, yes, but mostly for the treatment of bipolar disorder. What we are trying to do now is to try to disrupt this interaction between AKT PP2A and beta-arrestin by targeting directly drugs to the beta-arrestin. And hopefully this could lead also to disactivation of this pathway. Now we don't know yet that just doing that would be the proof that this pathway is how the drugs, that lithium is working. And we're far from having something that could be prescribed to human, but the hope is by being more precise directly on a relevant mechanism, something that has more efficient effects and less side effects can be developed. So this was a bit complicated, and just to close, I would like to remind that since about 5, 6, 10 years, because of the lack of new mechanisms, the big pharmaceutical companies have moved out. A lot of the research sector for developing new drugs for mental disorders, and the effort have been picked up by several charities, organisms that are funding academic research, and probably new solutions would come from academic research. So please support academic research, and thank you. I'm ready for questions.
Great. Thank you, Dr. Boileau. First question. When SSRIs are prescribed, one theory is that the brain creates added parallel pathways. What are your thoughts about this theory?
There is something happening of this style. I would not say necessarily parallel pathway, but the reactions with SSRI is taking time. So it's not simply increasing serotonin. It's there is an adaptation of the network of neurons to the higher serotonin that is helping for some people.
Great.
Other questions?
Thank you very much. Next question. Does lithium stabilize moods in both directions or just inhibit mania?
It's in both directions. It's actually prescribed for prophylaxis. It narrows the ups and downs and helps. When it works very well. It also have effects on suicidality. It's known to reduce suicidality.
Great, thank you. The next question, how effective is clozapine for bipolar disorder? I heard it is rather a dangerous medication.
Clozapine originally is something that was developed for schizophrenia. When used properly, it's okay. There is evidence that antipsychotics could be useful for some people with bipolar disorder. The problem with clozapine is it can cause a problem with white blood cells, and people on clozapine have to be closely monitored to avoid that this happen. Other antipsychotics would cause different effects. Some are linked to diabetes or massive weight gain. So there's no magic pill out there, unfortunately.
Thank you. The next question, are there concerns about the length of time someone is on lithium? If so, what is the usual management?
First aspect of management is the serum blood level has to be maintained. And one of the problems with lithium, and it's why it's interesting to try to develop alternatives, is it has a narrow therapeutic range. What I mean is that the blood concentration of lithium is at 0.5 to 1.5 millimolar in patients, and at 2 millimolars, it's toxic. So the people have to be very stable on a very well-watched regimen. Under short term, lithium is not dangerous otherwise. However, in long term, there are potential problems with thyroid gland, and the biggest problem is kidney failure. So eventually, after decades, it will have an effect on other organs. but we talk decades. I mean, if somebody starts on lithium at 20, maybe at 60 something, there could be problems.
Great, thank you. The next question. Oversleeping is not a typical side effect of Lamictal. However, a patient is sleeping 12 to 14 hours while on this medication. Could you explain why?
No, I don't know. I would say the patient should be talking and revising with the psychiatrist.
Thank you. Next question. Does valproic acid work in the same way as lithium?
We don't know that. We know that chronic administration of valproic acid to mice is inhibiting GSK3, just like lithium. Um, Valproic acid, however, is originally an anti-epileptic, and there's no clear theory at how it works. That's one of the theory. Another theory is that it may also affect, reprogram the genome to change the expression of some genes up or down. But there's no clear 100% sure evidence of how valproic acid is working. Same is true for lamictal, by the way. We know we know how it works as an anti-epileptic, but we don't know how it works for bipolar. And we know that not all anti-epileptics are working clinically for bipolar, so it's not that clear.
Thank you. The next question. Currently, I am prescribed both Cymbalta and Abilify. I recently added, I don't know if I'm pronouncing this correctly, Focalin. I've been without mania for over 5 years and no major depressive episodes. What is the contribution of this particular medication to this combination?
I don't know. I don't know this. The thing I observe, I'm not psychiatrist, I'm neurobiologist. The thing I observe from interacting with psychiatrists is that several doctors have a direct clinical experience. They know something worked, they cannot necessarily explain why it worked, but when the psychiatrist is good, what they prescribe could be very efficient. So it's, but short answer is I don't know.
Okay, thank you. The next question. When someone is on lithium, what frequency should lithium levels be done? Should liver and kidney function test also be done, and with what frequency?
Talk to your doctor. It's generally it's coming with the prescription.
Next question, where lithium is not acceptable for a patient, what is the efficacy of other treatments?
Lamotrigine apparently is very good for the depressive side of the disease, and valproic acid valproate more for the mania, and is not that good for the depression. That would be the first two places to move.
Thank you. Next question, what are the pros and cons between using Lamictal for treatment versus lithium?
The pros for same thing, the lamictal seems to be good for the depressive aspect more than the mania. The other thing is there's a question of cost. Lithium costs very little. And there's a question of not having to have the blood serum tested, but eventually the first question is what works. Is the patient responding or not?
Great, thank you. The next question, does a so-called subtherapeutic level of lithium make sense? Maybe both inhibit mood changes and reduce any damaging effects of lithium.
I don't know if it makes sense. As I said, if it works, it works. Um, proving how lithium is working would be a good idea. We don't know exactly where the floor is. because we don't have the clear biochemical target. So there's nothing rational yet on that.
Thank you. The next question. A young adult stabilized on lithium, lamictal, and Effexor has some memory and attention problems now. Could this be caused by the medications?
Once again, just like that, it's not possible to tell. I would certainly discuss that with the doctor because it's possible, but I don't know if it's the cause for this specific person.
Great, thank you. A patient's lithium level has consistently been below the therapeutic level of 0.36 mmol, yet symptoms are absent. What do you make of this?
That the person is responding very well. It's always the same question. If we understand how it does what it does, it's gonna be much easier to know who will get the best effect and which dosage will be the best. But yeah, if it works, fine. The symptoms are absent, good.
Great, thank you. Next question. Can you comment on ongoing studies related to marijuana or ketamine with relation to bipolar disorders?
For ketamine, what is known is that ketamine is helping for some people that are massive, untractable, depressive episode. So essentially, the case report I saw from ketamine is people walking in the clinic with suicidal ideation. They don't respond to any medication, and ketamine has been shown in clinical studies or case studies to work for that. Now, ketamine is an anesthetic, a stimulant at the same time. It's not something I would recommend to somebody to take chronically. As for marijuana, I have no idea. No idea of what it would do on a bipolar person.
Great, thank you. Does long-term use, 20 years plus, of aripiprazole have the same negative effects on organs of the body as lithium?
It's not the same mechanism. What you will have is more metabolic effects, but it's not the same thing for the rest of the body. The peripheral long-term effect won't be the same.
Thank you. Do you know how Latuda works with the body for bipolar disorder?
What works?
The drug Latuda?
I didn't hear the name.
Latuda?
Latuda. Okay. I just have to translate Latuda to its generic name. I said I'm not clinician, so. Okay, that's the synovial thing. It's another antipsychotic type of drug, one of several. Generally, these things are blocking receptors. That's all I can tell.
Great, thank you. See, do you need to be on a combination of drugs to treat bipolar disorder, i.e. lithium and valproic acid?
Not always. Some people are on monotherapy, some people are on polytherapy. It's a case by case question.
Great, thank you. Do you have a website that you
Yes?
can share with us where your research is published?
No. I should probably make one, but at the moment, no. However, it's easy to find me on PubMed, and several of the articles are on public access, open access.
Great, thank you. The next question, of your knowledge, long term, could valproic acid have negative effects or impacts on the brain or other organs, such as lithium?
On the brain, no. Once again, valproic acid originally it's an anti-epileptic, and it's derived from a natural product named valerian. Um, I don't think there is that many long-term problems. Lithium also is not that. I mean, it's well tolerated by several people. But yeah, short answer is that.
Great, thank you. As a neurobiologist, can you speak on whether Lamictal has been shown and proven to work well for both depressive and manic episodes?
Lamictal is more prescribed for the depressive episode. I know also psychiatrists who give it to people with major depression. Um, in the mice, it does work on both, actually. Lamictal, valproic acid, and lithium have pretty much the same signature in our laboratory animals. They change the behavior in the same way, and the three of them give something that is partially resembling an antipsychotic and partially resembling an antidepressant. So my personal guess is they probably hit the same reactions in the cell, and we have some evidence for that, but it's too early to tell.
Great, thank you. Can you comment on genetic and trauma factors related to bipolar disorder?
The genetic evidence is fairly strong. There are family of people with bipolar disorder. There are actually family of people with co-inheritance of bipolar disorder or schizophrenia. So one sibling would be bipolar, the other sibling would be schizophrenic. It's still debated in the literature whether the genetic risk factors are the same. Some people would tell you yes, some people would tell you it's not that obvious. And just in the case of schizophrenia, it's multigenic. So there's a recent paper published by a huge consortium where they identified 108 genes that are potentially involved in causing schizophrenia. So it's multifactorial, and it's possible that some of the proteins, the genes involved in one disease, also involved in the other disease. That would not be that shocking. But there's clear evidence. As for trauma, um, as far as triggering bipolar disorder, I don't know. But trauma or childhood experience are also able to change considerably how the brain will react, and that could certainly be a factor to consider. There's a whole series of research done on that. How trauma or experiences are reprogramming the genome and increasing or reducing the expression of some genes. So there would be that would be plausible.
Excellent, thank you. The next question, would you consider Seroquel effective for bipolar disorder?
Answer to this question is always the same from my part. It depends of the person, the patient, whatever as work. I know Seroquel is prescribed for some people with bipolar disorder. It's again an antipsychotic. What I presented in the presentation gives a bit of an idea, because if lithium is really touching a part of what the D2 receptor is modulating inside the cell, Seroquel will modulate this part in the same way. It's just going to have other effects also. But if it works for somebody, whatever. It's
Great, thank you.
next.
Are you aware of any physical effects of electroconvulsive therapy on brain chemistry?
Oh my God. That's a great question. Um, what is new of electroconvulsive therapy is that it's again something that works very well for some people with depressive and mostly depression. Um, what it does is like lithium, it's a mystery. Um, it There are some theories out there, but there's nothing. It's even less clear than lithium. So it's and what it does long term. The thing I heard about is memory loss, but once again, I never worked on that, so cannot tell more.
Great, thank you. What is your opinion, or do you have an opinion on mitochondrial therapy, for example, CoQ10?
I don't have an opinion. I would wait for a double-blind clinical trials, and I didn't read on the topic that much. I saw the last webinar here that was interesting on this, and I don't know more.
Great, thank you. How would you help a patient who is on trileptal for mood stabilization, but they seem to be held stably depressed without inducing mania?
I cannot tell. You should ask a clinician again.
And could my bipolar medicines be causing moderate leg life lipedema?
Again, if I don't know the person, I don't know the drug, I don't know the doses, it's difficult to tell.
Okay. The drugs are Lamictal and Geodon. That helps.
Doesn't help much more. The question is for any side effects, talk to your doctor and try to discuss the question. And if the doctor is a psychiatrist, that would help. So, I mean, somebody with experience that sees several people with the disease.
Great, thank you. It looks like that wraps up our questions for today. So I just wanted to remind everyone that this webinar has been recorded and will be archived on our website for future viewing. And thank you once again, Dr. Beaulieu, for speaking with us today. Very much.
Thank you.
Have a good day, everyone.